So go slow, interact with the audience, okay? Even the audience, if you have any query, you can raise your hands. You can stop Pashupati in between. You can ask him there and there, or even if you wait for at the end, we'll see whatever he have missed or wherever he could have improved. We'll give the collective opinion on his presentation. And as I was telling, most of the thing we have discussed in design and process resume, but in this chapter we look at specifically at pediatric population, at the target population. Okay, so let's start. Okay, Pashupati, you do the full slide show and start.
Hello, good morning everyone. My presentation today is drug dosing in pediatric patients. Introduction. Better understanding of various physiological variables that are regulating the fate of the drug is important to improve both the safety and efficacy of the drug therapy. In pediatric patients, so such physiological validity, and so it is important to select an appropriate dose of pediatric patient. Here organs are not mature. The development of organ continue until at least to the age of 12 years. And there is according to the classification of pediatric patients, according to their days and month and year. The preterm neonates, newborn infant is less than 37-week gestation period, and neonates is newborn infant birth to 27 days. Infants and toddlers is 28 days to 23 months. Young child is 2 to 5 years. Older child is 6 to 11 years. Aldosterone is 12 to 18 years. More than 18 years is that is adult. Introduction. The practice of scaling adult doses to the infants and children based upon the body weight and body surface area does not account for the development change that affect the drug pharmacokinetics or target tissue and organ sensitivity to the. For this drug, if you scale the drug adult drug dosing and infants based on the body surface and weight, but sometimes development changes also there in pediatrics. Some have less growth, they have some abnormality is there. Another is the chlorophenical induced gray baby syndrome is an example of potential dangerous inheritance in treating newborn based on dosing recommendation in adult. Another, in late 1915, a case report of unexplained death in the newborn who were receiving chlorophenical appeared. This death leads to the control of clinical trial of chlorophenical therapy is the premature newborn. High concentration of chloramphenicol and its metabolite accumulated in the newborn, presumably acquainted for the severe toxicity. This accumulation of drug dosing regimen that is intolerable in adult result from the reduce of capacity of newborn to metabolize the chloramphenicol by the glucuronide conjugation. Another is the rate of chloramphenicol metabolism was found highly age dependent, and half-life was 26 hours in the newborn, 10 hours in the infant, and 4 hours in the older children. Another therapeutic strategy such as this could be avoided by the performing pediatric pharmacological study during the drug development. Zidovudine is eliminated in the adult primarily by the glucuronide conjugation, suggesting that newborn may be reduced capacity to eliminate this drug. Unlike chloramphenicol, prior to the widespread administration of zidovudine to newborn and infant born to HIV-infected mother, the pharmacological and safety of the drug were carefully studied in this population, and age-specific dosing guideline were developed. And general consideration here, infancy and childrenhood is a period of rapid growth and development of organ system, and so carefully administration of drugs should be ensured. Term infant undergo rapid physiological changes in the total body water in renal and hepatic function during the first few weeks of life. CNS maturation with complication of myelination occur in the infant and toddler age group during the age of 1 to 12 years, almost 16% drop in extravascular volume. Doses in adjusted based on pharmacokinetic data of the given age group for the desired response, but considering each individual drug handling the capacity is often the most rational approaches. Absorption, according to the physiological, physiological change, there is a absorption, distribution, metabolism, and excretion. Depend upon that also, there is a changes of doses in pediatrics. Drug dose in pediatrics. So first, if gastric pH is 6 to 8 at birth, but they drop to pH 1 to 3 within 24 hours of the birth. Gastric acid secretion that decline eclohydia during 8 to 30 days and does not approach adult value until approximately 3 of age. The lower level of gastric acid secretion contribute to the increased bioavailability of acid level drug in neonates compared to the older children and adults. That example is penicillin G and ampicillin. Gastric empties delay up to 6 to 8 hours and irregular in the neonates and infant, but approaches in adult value by 6 to 8 months of age. Intestinal motility peristaltis is also irregular and unpredictable and only particularly depend on the feeding pattern in the newborn baby until the 1 month. In the newborn, decreased GI motility can delay drug absorption and result in the lower peak plasma drug concentration, but does not alter the fraction of the drug absorbed for most drugs. In older infant and children, GI transition time may be increased. Here, summary of the drug absorption in the pediatric patient. This is a physiological variable. Neonates, infants, and children. Physiological variable is gastric empty time is in neonates irregular, infants increased, and children slightly increased. Gastric pH, neonates greater than 5, infants 4 to 2, and children normal 2 to 3. Intestinal motility in neonates is reduced and infant is increased slightly in increase in children. Intestinal surface area reduced and infants near to adult. Children adult pattern, biliary function immature to neonates and infant is near to adult and adult pattern for children. Muscular blood flow reduced in neonates, increase in infants and children adult patterns. Skin permeability, neonates increase, infants increases and children near the adult pattern. Possible pharmacokinetic consequences. This criteria is oral absorption, intramuscular absorption, percutaneous absorption, and rectal absorption. In neonates, infant and children are different. Oral absorption is erratically reduced, increase the rate in infants near the adult patterns. Intramuscular absorption is variable in neonates, increase in infants and adult pattern in children. Percutaneous absorption is increase in neonates and increase in infants near to adult pattern in children. Rectal absorption is very efficient in neonates and efficient in infants and children near to adult pattern. And this one, distribution, as a result of this, the apparent distribution volume of water soluble drug is greater in newborn and infants than in adult. When normalized, the body uh, total body water equivalent for the larger fraction of the body in the new body weight in the newborn than in adult, older children and adult. There is also larger fraction extravascular water at adult. There is one um, how the premature, full term, 1 year, 10 years, how the fat and protein and water is, how much in the body. This one is the fat for 2%, premature is the fat 6%, mineral is 2%, protein is 12, and water is 80%. And mineral for full term baby, there is premature for 2 kg, and full term baby, if 3.5 kg is there, then mineral is 3.2, fat is 13.4, and protein is 30.4%, and 17% is water. And for 1 year, 10 kg, another is mineral for 3%, fat is 22.4%, protein is 13.4%, and water is 61.2%. And another 10 years, as is this weight is 31 kg up to weight. Mineral is 42%, fat is 13.7, and protein 70.3, and water is 64.8%. 15 years, 16 kg weight. Mineral is 4.3%, fat is 13%, and protein is 18.1, water is 60.6. In adult, 17 kg, and elder is 65 kg. That for 70 kg of adult, mineral is 5.5%, fat is 18.8%, and protein is 60.5%. Water is 16%. Another is adult is 65 kg. There is mineral is 4%, fat is 30%, and 12 is protein, and water is 54%. And distribution. As the result of this, the apparent volume of water soluble drug is greater in newborn and infants than in adult when the normalized to the body weight or surface area. That is, example is sulfadoxazole. Total body weight decreases throughout the first year and shift predominantly from extracellular to the intracellular flow. Dose adjustment has to be done to the drug that is highly water soluble like gentamicin to avoid ADA. Few lipophilic drugs have comparatively a large volume of distribution despite of lowered adipose tissue because higher portion of body fat than adult and highly affinity to these lipid. Example is diazepam. And serum albumin, alpha-1 acid glycoprotein, and total protein concentration are lower at the birth during the yearly of infancy. The total protein and plasma protein binding reach adult value at about 1 year of age. The reduced plasma protein binding in newborn is due to the occurrence of several factors such as reduced total plasma protein concentration associated with qualitative difference in plasma protein content. Fetal albumin has lower affinity for drugs and lower level of globulin and lipoprotein, a condition of relative hypoxemia associated with lower blood plasma. The higher plasma concentration of free fatty acid and unconjugated bilirubin, which may complete with acidic drug at albumin binding site. The possible presence of competitive binding substances of material origin. There is plasma protein binding and drug distribution summary is there. A criteria neonates, infant and children. There is a criteria is physiological alteration. If plasma albumin, fetal albumin, total protein, total globulin, and serum bilirubin, serum free fatty acid, blood pH. In neonates, plasma albumin is reduced. In infants, near the normal in infants, and children near adult pattern. Fetal albumin in neonates is present, in infant absent, and children absent. Total protein is reduced in neonates, decrease in infant, and decrease adult pattern in children. Total globulin reduce in neonates, decrease in infant, and near adult pattern in children. Serum bilirubin increase in neonates, normal in infants, and normal adult pattern in children. Severe free fatty acid increase in neonates, normal in infants, and normal adult pattern in children. Blood pH 7.1 to 7.3 in neonates, 7.4 normal in infants, children is 7.4 normal. And possible pharmacokinetic consequences, criteria, neonates, infant and children. There is a criteria is free fraction and apparent volume of distribution. Free fraction is increase in neonates, increase in infants, and slightly increase in children. Apparent volume of distribution, there is hydrophilic drug, hydrophobic drug, and tissue and plasma protein. Hydrophilic drug increase in neonates, hydrophilic drug increase in infants, and hydrophilic drug slightly increase in children. Hydrophobic drug increase in neonates and this decrease in neonates, and hydrophobic drug decrease in infant and slightly decrease in children. Tissue and plasma protein increase in neonates, increase in infant, and slightly increase in children. Metabolism, according to the metabolism, at the birth, majority of the metabolic enzyme system are either absent or present is considerably reduced amount of 20% to 70% compared to adult. Exception, sulfate conjugation is more. Gluconation is very less, therefore chloramphenicol is not bound extensively and so poor elimination metabolism, resulting the accumulation of chloramphenicol that leads to baby syndrome. Caffeine in children may have half-life of even 5 days, but adult is 4 hours. So drug that are extensively metabolized by the liver should be administration costly, caffeine, lidocaine, and chloramphenicol. In the most of the case, such a stage of reduced metabolic degradation is then followed by a dramatic increase in the metabolic rate of mainly phase 1 reaction. The increased metabolic deposition rate is usually very efficient from 2 to 3 months up to 2 to 3 years of age. Their value tend to decline gradually to reach those adult after puberty. Hormonal changes occurring during the puberty can also affect the drug deposition. Another important aspect, drug metabolism is dose dependent or enzyme capacity limited drug elimination that is important for all the age group. Drug metabolism in neonates, infants, and children. This is summary. Physiological alteration is liver and body weight ratio, cytochrome P40 activity, blood esterase activity, hepatic blood flow, and phase 2 enzyme activity. For neonates, infant, and children, liver and blood weight ratio is increases in infants, also increases and slightly increase in children. And cytochrome P450 activity decreases in neonates and normal by 12 months in infants, and children is slightly increases. Blood esterase activity decrease in neonates, increase in infants, and adult pattern in children. And hepatic blood flow decrease in neonates, increase in infants, increase near to adult pattern in children. Phase 2 enzyme activity decrease in neonates and increase in infants, and children is near adult pattern. And possible pharmacokinetics consequences, criteria, neonates, infant, and children. There is changes in pharmacokinetics. This is metabolic rate, pre-systematic clearance, total body clearance, and inducibility of enzyme. The neonates metabolic rate is decreases, infant increase, and children near to adult pattern. Pre-systematic clearance is neonate is decrease, increase